All right, what's going on, guys? So, welcome to the podcast. I'm really excited for this episode because today we've got Dr. Brent Peterson, and we're going to be talking all about COVID-19, public health policies, and some of the misconceptions around what's going on right now. And essentially, the intention of this episode is really just to get an expert opinion on, what the research actually says and just kind of clarify a couple points. I know there's a lot of misinformation going on in the media. There's things that I've gotten wrong. There's things a lot of us have gotten wrong. And so Brent is here to kind of shine a little bit of light on some of these things. So first off, Brent, thanks so much for jumping on, man. It's really exciting to have you here. Can you just give yourself a little bit of an introduction for some of the people who maybe aren't familiar with you?
Yeah, thanks, Daniel. Appreciate that. And thanks for having me on. So as Daniel mentioned, my name is Brent Peterson. I am an associate professor in the School of Science, Technology, and Health here at Biola University in La Mirada, California. My doctoral background is more along the physiological, and my doctoral training was in cancer and human physiology in that realm. So I played clinician, I played practitioner, all sorts of different things at lab, bench science, and in applied science as well. I have postdoctoral work in public health. And so original goals of that were to work directly with cancer and to be able to extrapolate some of the findings that we were coming up with scientifically, and to be able to relate that to people, which ultimately is what public health is about. And so where this is kind of led is I've got an incredibly great team here at Biola, and all of our labs, we're in LA County, and LA County is absolutely shut down. I mean, we're opening up, but things have been pretty shut down. I have a handful of research lines that shut down and haven't opened back up since March 12th of last year. And so we put our heads together. We really jumped on this COVID thing. So it's been quite a ride.
So I guess just to kind of kick things off, one of the things that I wanted to talk about was the actual transmission rates of COVID, specifically for asymptomatic and pre-symptomatic individuals. This has kind of been something that's a bit of a point of contention for a long period of time. It keeps kind of flip-flopping back and forth. And there was a recent meta-analysis. Let me see if I can pull this up here. There was one that was done in Wuhan, but then there was, let me just see. There was one that was published in Nature, and I'm trying to see if I can pull up the other one. But at any rate, it essentially was looking at the transmission rates, and it found the secondary reinfection rate was extremely low, almost negligible in some cases. And I mean, it seems like there's quite a bit of conflicting information that's kind of being shared publicly. And so I just wanted to get from your perspective, what does the literature actually say about transmission rates? And then we can kind of go into, what that means a little bit down the road.
Yeah. So I think you kind of hit the nail on the head with the concept of transmission rates. I mean, at first we got to define what the difference is between asymptomatic and then pre-symptomatic. And essentially what we're saying is asymptomatic is no symptoms whatsoever. Pre-symptomatic are maybe mild symptoms, or there's a that feeling that you get when you're starting to get sick. So we say pre-symptomatic, but you're not quite there. So there's multiple definitions, I would say, that are kind of being floated around. And I would say when it gets out to the general public just kind of throws those in interchangeably. And that's one of the challenges, I would say, for public health practitioners, is defining what this is. The other thing too is, and I've read, a handful of those ones. I believe I've looked through that meta-analysis that you're talking about as well. And the transmission rate, I would say, is one of those numbers that, again, we're still so new into this thing, and we can take research and we can make it say a lot of different things. Not to say that there isn't any relevance to what is being said, but we have to be careful with taking that and taking a small bit of information and saying, okay, this is going to fit everybody on the globe, because part of these transmission rates and part of how they're looking at these things, some of the scrutiny has come in relation to methodological considerations. Because if you're doing a study like this, you're looking at, most likely, there's demographics of a region. You're looking at people specifics. You're looking at population specifics. You're looking at all of those very localized factors. And what we try and do in research is take that number and try and extrapolate it out. So I would still say that, and the numbers have bounced around a little bit, and that's where some of the challenges are. And public health tries to get ahead of this by getting some of that information out. But I would caution readers when you see these numbers thrown out. I mean, they've changed a lot, and so you want to err on the side of caution and say, okay, well, I'm going to do some homework on this, follow up, look at the literature, see where this is coming from, because a lot of where I have seen some of these presented outside of an academic setting have been kind of in the socialized world. And so, from an academic standpoint, we usually take a step back and say, okay, well, yes, this is what it says. We will try and, do what we can with it. But we need to look at, okay, so where was it? Who were the subjects? How was this applied? And what was the setting? And that's where I think the general public may be getting a little bit of confusion, or maybe even some lack of clarity on some of these things. For example, the number, well, I guess R naught, the R1 or R naught value that is used to model some of this, basically utilized in public health as a measure of suggesting that if the number is below 1, that potentially the virus could sort of take care of itself, in essence, or peter out. But if it's over 1, there is some leading toward it keeping on proliferating. So those numbers get thrown around, and sometimes it's like, well, this number, we have to rely on this 100%. We have to say, well, this is exactly this. Well, there's context. And I think that's where some of the challenge with public health, trying to convey information, the details are important. And this is where I think this is some of the problem. So.
Yeah, no, that definitely makes a lot of sense. And just kind of piggybacking on what you were saying, can you go into a little bit of detail when it comes to utilizing masks? Because a lot of the research I've seen, and this is a discussion I've had, just kind of in private, I don't tend to post about these things too much, but even just a lot of the efficacy of masks, for instance, is based off of studies that have been done in like randomized control trials under medical settings, which is very, very different than free living scenarios where utilizing masks in a completely different setting. You're not changing them always, you're reusing them every time. So can you kind of explain, or just kind of touch on some of the discrepancies between what we see in wearing masks in free living scenarios versus some of the studies, and what some of the dangers might be in terms of even just like a false sense of security where you're wearing masks and kind of getting close. So just, feel free to kind of go wherever you want with that.
Yeah, this is a fun one. So the challenge, I would say, and you're spot on, is that when you take a highly controlled scenario, you have a highly controlled scenario, but we're talking about people who do not have the training to understand. I mean, typically, I'm talking very generalistically. If you're talking about the general population, to ask them to be able to utilize some form of PPE, but not give them training to do so, or even the process of disposal, care, maintenance, all of those things. So I would say that, in evaluating the literature, it does kind of go back and forth. There is some equivocality to what is being presented as of what I am aware of today. Now, that can change. But again, the point being with these masks is, there still is some questions about, okay, well, you hear early on that what's recommended is, well, you don't need to wear one because we need to keep the N95s for the medical professionals. Then it's, now you need to wear one face mask. And then that changed. And then now it's 2. And you should really be working hard on making sure the fit is precise. And then you have another covering on top of that. So, there is a message of trying to get a hold of this thing. But the other hand is there's a mismanagement of a message in going from one to the next and kind of going back and forth. And so, it's a tough thing, I would say, for public health practitioners, because they're trying to, and even in some of our early papers, we even suggested that in looking at the way that the United States approached the pandemic early on, we called the U.S. out for failure. That's one of the things that we had mentioned. But we had also recommended masks early on as part of the protocol. And one thing that we're reevaluating as a group is we never set an endpoint. And so I think now people are, it's different depending on where you go, but I just read today that the state of Montana, among other states, have actually backed off on a statewide mask mandate. So one of the challenges I would say with, the equivocality of the literature, not really going one way or the other. I mean, there's pluses and minuses on that have been presented both ways, but then the policy differences between state to state, and even county to county. I'm in LA County, and it looks a lot different here than it does in Riverside County versus Orange County, or even another state like Florida. So there's definitely some questions about that too. So another thing that I often mention to people, and there's varying opinions even within my research group on masks and whether or not we should be wearing N95s versus a single face covering or whatever. But the one topic that I bring up oftentimes that doesn't seem to get as much scrutiny is the fact that have we trained the public to be able to don and doff PPE, right? That's the technical term for putting it on and taking it off in an appropriate manner. I mean, we have to go through, there's a long process of training, and I go through a process of collaborative institutional training initiative. So you go through biomedical and hazardous training, and we get other sorts of PPE training. And to have the public just do something that we're trained to do. You look at the medical professionals, there is protocol to how you use PPE. And so that has been a question of, okay, so is this something that we're looking at? You could go outside and watch how many times people fiddle and touch their mask. Every time I see that, I go contamination, 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 right? So there's a lot of nuance. There's a lot of interesting things with this, but from what it appears, it's another thing too about the timeline. How long is too long to have some sort of a public health intervention? And just to reiterate, we did say we were recommending masks early on, but we never set a cut point. And others have I think tried to add to that to say, we should have responded this way, but we didn't. And, they've tried to add to the cut point of like, okay, this is when we need to start really reevaluating this entire policy. But, what it appears to be is that as these states start to relax, I think there is a level of frustration that is growing. And, that's partly our fault. And I would say that there's public health practitioners that are probably saying the same thing too, going, we messed up. We didn't give a timeline. We didn't give, and it's hard to do, but when you ask the general public to do something and to adhere to a policy for these reasons, and then part of it is our mismanagement and our lack of keeping a consistent message, that's another thing that's added in some challenge too. And I think people are getting tired of it. I think people are just getting tired of having to wear these face coverings, especially now that the doubling down recommendation has come out. So it's messy, but I check the literature, every other day to try and see if there's something new that's coming out. We have even toyed with the idea of trying to do something a little bit more, maybe not a little bit more controlled, probably a little bit less controlled and a little bit more like normalized society. So our research group is trying to see if we can put something together that looks a little bit more like we can, attribute the data to a larger population.
Yeah, I'd definitely be interested to see how that turns out. It sounds like a lot of the research that I've seen seems to lack a certain level of applicability in the same way that, like a metabolic ward study, they're like, see, calories in, calories out. And it's like, well, yeah, it's not a surprise. Like,
right.
No one lives in a metabolic ward. So one thing that I also wanted to touch on was the how a lot of the statistics and the data is kind of being presented, right? Like, we're testing for cases, whereas we haven't necessarily done that before with the flu. And there seems to be a lot of contention among virologists and other, public health officials. We're like, whoa, we shouldn't be doing this because it's not necessarily indicative of whether or not we actually have an issue, like the dangerousness of this virus. And then you see, other stats like the 99.8 or whatever percent recovery rate. And it seems to be these really conflicting things where we have all this data, and it's like, a lot of I'm not sure in the US, but in Canada, the flu, there's like zero flu deaths this year, which just doesn't make any sense, right? And so it seems like there's a lot of tampering with data, whether intentional or unintentional, doesn't really matter, but well, it does matter, but you know what I mean?
Right.
To us, it doesn't necessarily matter. And so I was wondering if you'd be able to just kind of speak to that and maybe point out what you would like to see as far as like how to parse out the data and how to clarify some of this, jumbled mess of research, and then to kind of, how we would share it to the public.
Yeah, that's an incredible question. I think the challenge of the data right now, I don't know if you're aware, but there's been a lot of either resignations or people have been, for various reasons, left their public health office, wherever that is. There's been, there's a list of people that are no longer in charge of these public health departments. And so I think that's one piece. Another thing to consider too, and I had spoken with a colleague of mine who actually had background at CDC prior to coming here. And one thing she mentioned was, because I asked her, I'm like, what's up with all these people? Why are they leaving? Are they getting fired? What's going on? And so one of the challenges I would say too is that there's been a history of underfunding or under-preparing some of these public health departments, which, by the way, as part of this, they're the ones that collect the data. Now, I can't necessarily speak to the intentionality of some of these groups because I don't know that, but I look at the data and I go, what's going on? I mean, there's certainly questions about, why is it that we're not looking at the flu like we used to, or, the question about the tests themselves. And there's a handful of products that are out there. In fact, I'm advising a group in this area on trying to find a cost-effective test that they want. And I mean, they even do testing on campus. And so, early on in this thing, we had the nasopharyngeal test where they were doing the swabbing, and then they were shifting to another form of test. And I mean, so what we try to do in research, and again, this is coming from the physiologist, not the public health practitioner. We always look at things a little bit more to the individual standpoint. This is where I differ from my colleagues a little bit. I'm individual up, they're global and populations down. And so when we look at these things, I typically say like, okay, so wait a minute, we're midstream and we're changing the test. That's a question. Like, when you're in a research study, the test is a test and you keep that throughout, right? So could that be part of the discrepancy in the data? Perhaps. Could it be a change in policies? I believe it was a couple weeks ago, the sampling rate for the PCR test was dropped down to a lower category. And, when some of these things change, that does have an impact on what happens with the data. So in fact, I looked up real quick prior to our meeting about some of the flu numbers, and it doesn't sound like there's a really solid, at least from the couple of articles that I looked at, it doesn't really sound like there's a solid answer as to what the discrepancy is. So I can't really speak to that, but that's what the data say. I mean, the data show that there's very, very few flu deaths and all these COVID deaths. And so I think that's going to take some researchers to plug in and try and see what exactly might be explaining that. But again, my thought is that you've got these public health agencies who are underfunded, understaffed, under-resourced to begin with. Then we get hit with pandemic. And then all of a sudden now there's this, secondary or down wave effect where these people are now being fired, they lose a job, and they're probably the people that are maintaining the statistics for the region, which then go into the national numbers. So I don't really have a formalized answer other than what I can try and guess on that. But, it is messy. It's a mess. And, when we're talking about the recovery rates too, you don't hear that as much, right? We don't talk about the recovery rates as much. And we actually are planning to do a kind of a position stand piece. And so again, I'm coming from a field where a lot of the folks are in the prevention side of things, and the exercise is medicine and nutritional intervention. I mean, so when we talk about a position, not a position stand, a call to action paper saying, hey, we should be looking at this to try and help that situation. But as part of this, I do think that there really is a lot to consider with that data. And so I don't know if that really helps a lot with that, but I mean, it really is multifactorial and it's kind of a mess.
Yeah, I mean, it's definitely a little crazy, right? And I mean, someone in your position would probably be a little bit of a nightmare, right?
Yeah.
Because there's just so many variables. But I mean, personally, I'm always a little bit skeptical when I just see these kind of dramatic changes where it's like, so yeah. even just numerically, right? Like if something has a fairly high recovery rate, how could it possibly cause millions of deaths in Canada? So when I hear that, I don't know. I guess like one of the big concerns that I have and that a lot of other people have here in Alberta is around the world, right? Is in this sense, it seems like the antidote is worse than the poison, right? We look at the massive economic crisis we put ourselves into. And I mean, the correlation between economic prosperity, recessions, and mortality rate is pretty hard to separate, right?
Yeah, so, totally.
And that's obviously not something that you can really plan for in this sense, but what are your thoughts on some of the policies that maybe aren't necessarily, that you maybe necessarily don't agree with? I don't know if you feel comfortable talking about that. And then what are some policies that you really do think are good and that you do agree with? And just any sort of maybe recommendations or thoughts on current things, if that makes sense.
Yeah. So initially when we were one of the first papers April of 2019 to come out and say, hey, this thing might actually be aerosolized, so we should be thinking about doing something. And so we followed that up with a couple papers, and a couple in particular. We did a couple of meta-analyses where we looked at the rates of death, and we looked at who was dying, and we came up with some numbers that are reflective of what's being shown today. And this is last year, that essentially men over the age of, now at that time it was 65. Now that number has changed a little bit. Men over that age who have one or more comorbid conditions such as obesity. And so as part of that, one of our subsequent papers we came up with was looking at the United States and how the United States responded. And so we started comparing back to what happened in 1918. And so the thought with that is, and where our stand was based off of what we understood at the time, was that, if something is that dramatic and it's spreading so rapidly, there is some benefit to shutting down for a period of time. Now, that again, as I mentioned earlier in our talk, is something that we're going back on and say, not necessarily going back, but we're saying maybe we ought to put a end date on that. And so we're trying to figure out how we can approach that. But early on, and early on in the pandemic, the COVID-19 one, what we had suggested was early on, let's shut it down, for a short period of time, keep people more isolated, more quarantined for a period of time, and then, start to relax from that point. But the point that's a discrepancy and a challenge among many is, well, that's great if everybody does it, right? So it's great if everybody is unified in that process. And so public health wants to do kind of broad, widespread. Everybody shuts down for a period of time, and we stick to those guidelines, but that's not what happened. I mean, and so people live their lives and they do different things, and there's that is where we came up with one of those challenges. And you can't control for that, especially when we're putting together a study. We're like, hey, this could be the thing that does it and works. Then you see what happens, and then it's like, okay, well, let's go back to the drawing board and rethink how that is. So, I would have to say that one thing that's important is the messaging, and that didn't work well in the United States. Other nations did a good job. Now, we compared against a couple of other countries. I believe it was I think we did Sweden and I'm losing track of the other one. Anyway, smaller island nation that we looked at as well too. New Zealand. Thank you. And so you've got a different situation over there. You've got a landlocked island, and the population is the population within that landlocked island. And we're talking about the United States, which has a lot of international travel. Granted, we did slow that down. Or even shut things down for a period of time. But I would have to say that, our group would probably still suggest that early on, you have a very brief, define that though. I mean, we don't really have a timeline, a very brief window where things shut down, people kind of isolate a little bit, stick to, let things kind of, the goal of 15 days to slow the spread clearly didn't work. So, what do we do with that now? As far as those policies, we now have to consider that, and I'm working with some psychologists on this thing, and I'm no psychologist, but it's pretty evident when you walk out in public that something has changed, right? I mean, I try and do my daily activities, and I try and, go out into the public, and I'm a social person, and, still do all of my errands and things like that. But you could just tell that it's had an impact on people. And, the social isolation has been a target of some of the folks, not a target, but it's something that they are highlighting as this is a big thing. This is something to consider. Granted, at least the psychologists that I'm working with are pretty strapped because they can't spend the time doing the research on it because now they're practitioners and they're working with the mental health side of things that has bubbled up now because of it. So the mental health, the loss of jobs, and that does a big thing on people. And I think we have to start considering those things as a consequence of these public health policies, and by in part other things as well too. But the policies do have an impact. And so I think public health needs to take a step back when we can kind of regroup and rethink some of these methodologies, because the job loss is huge. And I don't have a number on unemployment rate, but I come from a construction family. And so I understand what that line of work means. And if you're out of work, and you don't get to work, that's pretty much your paycheck and food for the next couple of weeks. I mean, because a lot of that is living paycheck to paycheck, and that's hard on people. And so I think we have to reconsider some of those things. The other thing to consider too, and I have a couple notes on this. So the isolation, I don't know if anybody's done any psychological studies on what it means for a society to constantly have masking. I mean, I don't know of any studies that have looked at it from that perspective. And so, is that something that has an impact on policy later on? I would say it should be considered. But the other thing too is that we've got to think about the next generation with kids. And there's some folks on Twitter that I follow who are the doom and gloomers, and they are pushing fear to the max. But then there's others that I follow on Twitter who have more of a balanced approach. Some that are pushing for opening the schools for the kids. And I mean, the data are pretty clear that kids are very, very low risk, and getting these kids back to school, getting them into a normalized circumstance where they can work toward their education is important. So the societal factors, the psychosocial factors, I think we need to rethink some of that as it relates to public health policy, because, we probably early on, and I'm trying to think for some of the public health experts who had to make some of these decisions. My thought is that, oh my gosh, we have to do something, and let's just throw what we have at it and hope it sticks. And then we've been revising as we go. So I don't know, does that help?
Yeah, no, it's definitely like, I feel like each one of these questions would require like a 10-hour lecture to really at
There's a
least.
lot to unpack.
Yeah. Yeah. Well, one of the concerns that I definitely have is kind of the discord that's going on right now about, between either side, right? Like, um, I have my opinions, and like whenever I'm speaking about something, which on my fitness page, like on my professional page, I don't post anything about it.
Yeah.
I usually just will be like, hey, we need to do something about, mental health and just,
Sure.
and stuff like that. But anytime that I've spoken about something, I'll always be like, there are certain public health policies that don't make sense.
Yeah.
And then usually what's met with that's met with like, well, you don't care about lives. And I'm like, wait, what? And so it's like, if you're for lockdowns, you care about lives. And if you're not for lockdowns, and you don't care about lives. And it's obviously not that simple.
Right.
There's a pretty big divide between those two. Like, even for instance, what you were saying about, the children, because on the one hand, as a parent, you might be like, well, I don't want to risk my kid, even if it is a small risk. Sure. And at the other side of things, the literature is real clear on socialization. If you're not socialized by the time you're 5, the likelihood of you ending up in prison is like exponentially higher.
Pretty high.
So these are some very serious trade-offs, not just for children, but even like businesses going into bankruptcy, where it's like, that's not something you can ever come out of, and
right.
What are some of your thoughts on how we could navigate, just like as a whole, how we could navigate some of these conversations, with a little bit more understanding of both sides? And it's not a matter of, if you care about the economy, you don't care about lives. And if you care about, lives, then we need to shut down. It's not necessarily this dichotomy. So how would you navigate those conversations?
Totally. Yeah. I think the approach that I've tried to take, again, because I wouldn't say I'm an outsider to public health, but public health wasn't my main background. And so it was an after the fact thing. And so my formalized training is not in that large scale application. So what I think the conversation, oftentimes when I have these conversations, is, hey, are you in a place where we can have a conversation about this? And are you feeling like we can have a little bit of tough dialogue back and forth? Do you want to talk about some of these things? And, I almost wonder if the challenge for both sides, and I always try to be able to navigate between both, because, everybody's opinion is valid. And I think we need to consider that there are other thoughts that, we all have our own thoughts, and that's a good thing. We need to be thinking critically on our own, no matter what. That's an important thing that I always tell my students, that, you gotta be able to think critically on your own feet. But I think that trying to have a measure of collegiality is important, and having conversations with people that want to be collegial in that. I think there's coming to the table and saying, we agree, but let's find out what we can agree on, and let's see how we can maybe fix some of the things that maybe you don't like, or maybe some of the things that I don't like. And I don't know if that's happening. I know in my circles, when I talk to folks, that are in the public health, or, in the more basic or applied sciences, I try to say, okay, so this is my perception. This is the way that I see it. And how do you view it? Like, what do you view it as? And I think my colleagues have been very understanding and very kind about those things, that, we can come to the table and have some of these conversations. But, I don't know, how do we generate that out in the world today? That's kind of a hard thing. And so my hope is that we could get people in a room who have all different expertises and say, let's dissect what this looks like, whatever the topic is, and just say, let's just pinpoint a couple things and start to say, well, what can we do better on that end? And getting past the thoughts of, okay, if this person is for lockdowns, are they're against this or whatever? It's become a for against thing, instead of a, I value this because, and this is important because. And if we could get these folks to come to the table and have a dialogue, maybe we could get ahead and make some policy changes that are going to impact and better everyone. But I'm hopefully optimistic.
Yeah, no, and that makes sense. And it's funny too, because like whenever I talk to people about this, if you really do take the time to like have that conversation and like ask
Yeah.
follow-up questions, like when you say you think we should all be wearing masks, why do
Mhm.
you think that? And it's like
Right.
it's not because wearing masks is so important, it's because they don't want anyone to get hurt and so on and so forth. And it's like
Sure.
I think that there's a lot more common ground than it appears a lot of the times.
Sure.
But because these are like, it's pretty difficult to know why someone has a certain stance. Like for instance,
Yeah.
my grandma is 98, right?
Mhm.
She lives alone. She's self-sufficient. Um, Realistically, she probably doesn't have that many years left.
Mhm.
So isolation for her is probably not a good trade-off
Right.
for spending the last couple of years of her life, right? And so
Yeah.
it's like that's, she is an at-risk population individual, even though
Mhm.
she's reasonably healthy, like,
Yeah.
but at the same time, it's like, is that really how she wants to live the last couple of years of her life or the last couple of months or whatever it might be? And
Right.
it's like you wouldn't necessarily know that unless, like, I have my grandma. I talked
Right.
to her and she's like,
Yeah.
yeah, I don't care. She's like, if it happens, it happens. But that's not necessarily something that's at the forefront. It's usually we need to protect these people who are at risk.
Right.
And sometimes those people don't want to be protected. Sometimes they do.
Totally.
Sometimes people who probably aren't really at the greatest risk of anything
Yeah.
do want protection because they maybe don't necessarily have a realistic understanding of their
Mhm.
actual risk. And
Totally.
there's a lot of communication breakdown. And to be honest, social media is horrendous because
Yeah.
it's always like, I'm reading these things where it's like, we have 100, I can't remember what it is. Someone literally said every week there's 200,000 deaths in the US from COVID. And I was like, that's literally impossible.
Yeah.
That's not possible. You guys have 320 million. That means
Yeah.
in like what, a
Yeah.
couple of years, everyone's dead. Like, what are you talking
Yeah.
about?
Right.
So there's so many things and there's not really any fact checking. And it's one of those things where
Totally.
you hear it, it aligns with whatever you believe. And then you're like, I'm running with that.
I'm going with it.
I'm dying, Yeah, so it's definitely a tricky thing to navigate, but I think you definitely hit the nail right on the head as far as like just being like, hey, like, are you cool with talking about this? Like, where are you coming from, asking those follow-up questions? One thing that I did want to talk about a little bit more, I'm not sure if this is, a little bit out of your scope or not.
Sure.
Were, the relationship between social isolation and like substance abuse, suicide,
Totally.
like that. Right now, I know I've heard some conflicting views on whether or not suicide rates are actually going up. But I think my opinion is there's a little bit of a kind of a lag before you're going to see that data.
Yeah.
And what we usually see is kind of what we're seeing right now, where you have this big influx of, calls to suicide hotlines and things like that, where that is indicative of, something that's going to happen in the future. So I just wanted to get your potential ideas on that situation. What are some of the things that we could potentially do as a public to kind of unburden some of these individuals?
Yeah. Well, I mean, speaking with my colleagues that are in the psychology side of things, they're saying that these things are happening because they are working with patients now in their clinics because, like I said, now all these mental health things are happening. And again, that's not my area of expertise, but I can vouch for my colleagues who are saying, yes, we are seeing these things are happening. Now, has it been reported on a wide scale? I would say it probably isn't as much. And the lag time you're talking about is probably because they're so burdened right now. And I'm using the folks that I know and the little data that I have looked into on this as kind of the guidepost on this. But what they're saying is that we have so much that we're dealing with all of these patients now that we're seeing for a whole host of different things. But isolation is one of the biggest keys that they have highlighted as, social isolation. I mean, we're social people. I mean, we need people. And so when is too much too much? When is that isolation point too great for some? And the addiction, so some of the drug and alcohol issues are definitely increasing. I think we're going to still see numbers on that. That's something that I'm expecting that the numbers are going to increase based off of what I know and what I hear today. Same thing with suicidality. I mean, it's certainly it's something that we need to consider as public health. You know, what are the costs? Is like you said, is the response doing more harm than good if we're seeing X, Y, Z, 1, 2, 3? And unfortunately, I think time is going to have to progress a little bit before we actually see some of that manifest as a collection of data points. But you know, I definitely, it's been an important thing for me. I've got 4 kids, and so I mean, we are very, very careful with them, and you know, we have close groups that, you know, are comfortable with being around together. So you know, my kids have that social interaction, because you know, I see it in some of other people I know, some of their kids, and being withdrawn, and again, this is only anecdotal from my own perception of things and from a few people. So, I mean, it's not extra, you know, you can't, you know, take this and say, this is what it is. But, you know, I think we have to be careful about this. I mean, we have to think about what can it be doing to these kids. And I saw a video early on in the pandemic, actually, I would say probably in the summer of summer of 2019. Then I think that's when it was. A dad was talking about his son, and he said, you know, he's talking about how his son was this wonderful kid, and he, you know, he was working on he had these video games that he really loved to do, and then with the pandemic, you know, all of these things started to happen and change in his son, and then at the end, he's like, my son killed himself, and I'm like, as a dad, you know, you just can't. You know, those things are like hit you to the core. And so, you know, that's like seared in my memory, you know, now when I'm like, okay, how can I impact this? How can I connect people? How can I try and answer some of these questions? And so, and again, I'm no psychologist, but I know psychologists. So I'm like, let's get together. Let's talk about some things. And so we actually wrote a paper in 2020 on social isolation and patients who were dying during that time. And so right after we wrote that, we kind of were just identifying that the process is not a good process. I mean, I get the thought process of the physicians behind it, like we need to just close them off. But, you know, we have people that are dying and they don't get to be with their loved ones. And so we need to reconsider some of these things, think about the impacts of that. And so we're looking to follow that up on some of these other isolation pieces. But like I said, you know, my colleagues are in the clinic now, and they're working with people who have a lot of stuff going on. So yeah, it's certainly not as talked about as I would hope, but I don't know exactly what can explain that, but it's important.
Are you familiar with any resources or anything like that that maybe people can access online or something like that?
Related to mental health?
Just related, yeah, mental health, anything like that.
You know, I could ask some of my colleagues. I mean, that's not anywhere in my realm, but I could ask some of my colleagues and see if they have resources on that, and we could follow up again on it.
For sure. Okay, cool. Yeah, and one of the things as well, like as far as like the fallout from all of this,
mm-hmm.
that one of the things that I'm thinking about is definitely the relationship of policing in communities, right?
Sure.
I know not too long ago, I saw a video of a gym owner, like
mm-hmm.
people rushing out of the gym.
In New York?
You saw that? I
yeah.
think so. He was like maced and arrested, and it's like
mm-hmm.
for opening up his gym. And it's like, on the one hand, I understand, but then on the other hand, once this stuff is over, people are going to be real mad, and there's a lot of like tension that's going to be had. And like, to be clear, I'm 100% police. Like when people say defund the police, I do not agree with that. That is a bad idea. There's so much evidence to support that it's not a good idea.
Yeah.
So I am very pro-police. I think that they have an incredibly important role, but I think they're
mm-hmm.
also in an incredibly difficult position.
Oh yeah.
Because
totally.
On the one hand, there's a government mandate that's saying, hey, we want you to, arrest people and give them tickets and give them fines. And on the other hand, it's actually against the Constitution.
Mm-hmm.
Like in Alberta here, there's I can't remember exactly what it's called, but there's actually a law firm that's taking on every single ticket that's ever been issued, and they're doing it for free.
Oh.
And they're all getting thrown out because it's
Mm-hmm.
unconstitutional for ticketing people or arresting people for
Yep.
social gatherings.
Yep.
Or I don't know exactly all the tickets that are being issued, but it's a really tricky situation for them. And I mean, a concern of mine is definitely like how people are going to be responding to the police after the fact, you know, because whether or not you were participating in that or not, I think all police are going to kind of be painted with the same brush. And
Perhaps,
hey, you know what, you did this, you shut down businesses, you know, now I'm broke, I can't take care of my family, it's your fault.
Mm-hmm.
Has anyone in the public health, I guess, sector, sorry for me butchering terms,
no, you're good, man.
Have you heard anything about this, or any sort of strategies to kind of manage some of the fallout between government, the mistrust, the police, any of that stuff in the community?
In any of the conversations that I've had over the past year with, you know, numerous people, it hasn't come up once. And that is probably, oh yeah, I mean, it certainly should. It certainly should be something we talk about, because you're absolutely right. I mean, and I think this goes to the point of when things become overreaching and it's too much, too far, how much can people tolerate, you know, and knowing that there are constitutional guidelines that you know, law enforcement or other authorities are supposed to be abiding by, you know, what's the point of too much is too much. And so that would be another one where I would hope that you know, the parties of law enforcement, whoever's in charge, and public health officials could come to the table and say, hey, let's try something different next time. Or, you know, this worked, this didn't work. I don't know. I do know I have some very good family friends, some in LA County and some in Riverside County, and they're not enforcing stuff. And sheriff or LAPD, and they're not enforcing things because of some of these litigation things that have happened, that, you know, people are bringing their tickets and they're throwing them out. So, you know, that's one of those challenges where I think every region of the country, every state, every small town, I mean, it all looks different. And so, the legality of it, and, you know, at what point has there been an overreach somehow? I think, you know, the courts are probably going to determine what that looks like, but you're absolutely right. I don't know of anybody who's talking about this, and they should.
All right. Yeah. Fair point. So sorry, these are just more, I guess, intellectually interesting topics.
No, it's great, man.
Kind of chat about, but kind of getting back onto something that's a little bit more specific to your area of expertise anyways. I wanted to talk about some of the like recycled drugs, some of the things that we've heard quite a bit about. I know everyone's heard about like hydroxychloroquine, and like ivermectin was one of them. And I'm sure there's a whole host of other ones. So I know there's a lot of, I don't know enough about this stuff to determine which one is bullshit, which one is good, or under what context that each one of them works.
Right.
So could you just kind of speak to either some of the drugs that are being recycled, that are being used, that are also having some efficacy, and then also just those two, because those are probably the ones that are a little bit more prominent in the public space anyways. Yeah.
So hydroxychloroquine, the azithromycin and zinc combo is being used, and that probably we've had discussions with a number of different infectious disease specialists that are actually treating, and a lot use that. And I did some clinic time over the summer, and they were prescribing it to their patients prophylactically, and as a treatment modality. But there's also physicians who are doing a lot of other things as well too. I mean, there's a huge list. I looked up a list, and I've got notes here on like 15 different drugs that range from some antivirals to some of the anti-inflammatories, some of the steroids that are being used, to convalescent plasma, to monoclonal antibodies. There's a lot that's going on, but interesting that you mentioned ivermectin. Ivermectin I don't know if you caught it was the Senate Judiciary Board, I believe. He went before, it was a physician who went before our Senate Judiciary Board and was basically pleading with them to consider looking at ivermectin. So I know that there's some very large clinical studies, clinical trials that are going on utilizing some of these things. But is it universal? As far as what I am aware of, I don't know if there's any universal treatment that has been put out there as this is the gold standard for what you should do. I do know that it appears in the literature that more physicians are working toward proning, having the patients in a prone position for better breathing, and on the steroid. Now, again, that depends on every hospital, every physician. I believe that they have, the authority to make those decisions. But it appears that there is some overlapping and some universality in some of those drugs and some of those treatments. But this changes often, right? So early on, hydroxychloroquine was not recommended. It wasn't one of those things that they said, no way. And in the United States, there was big backlash over that. But now more recently, it's kind of been backed off. And now it's not under the scrutiny lens that it was earlier on. Remdesivir was pushed early on, or Regeneron. And Regeneron, I haven't heard too much about lately. Regeneron, but remdesivir was actually not recommended. I mean, it seems like it kind of flip-flops that based on, how that information gets carried up forward. So, but there's a ton of different treatments that are out there, which is pretty amazing, to think about that we have these things. A couple of the ones that I actually wasn't aware of is that there are some physicians who are using Tamiflu and another one that's called Avigan, Avigan, and I wasn't aware of those, and I haven't read too many things about those as well. But even some gout medications, some physicians are using that as well. So, I think it speaks to the creativity of physicians to know their drug platforms, right? What do they have available? What can they use? And to be able to try and put those things into practice. I mean, if we have them and they're available and they're lower cost because we've had them for a long period of time, well, let's try it, right? If there's some efficacy to those things for other similar conditions, whether they be antiviral or something like that, I think that's probably what we're seeing now is in these recycled drugs. I even heard too some cancer drugs. I believe this one here, I posted about it on Twitter, coming from the NIH, lidadepsin. And I haven't heard of that drug before in the past, but yeah, some of these cancer drugs are starting to be repurposed for some of this as well. So I think still the information is forthcoming. I couldn't tell you one way or another at this point, this is the gold standard for what is being done. But yeah, I mean, the infectious disease specialists that we have spoken with and other physicians that are in my network have said, I have used this and this is what I've seen. And so that's what we have to work with.
Awesome. And as far as the vaccines go, I know that's kind of a big point of contention as well. First off, I was hoping that you could just kind of touch on the mRNA vaccine. And I know a lot of people are concerned that it can change your genetic composition.
Right.
And I was wondering if you'd be able to just kind of like clear the air on that really quickly.
As far as I'm aware of the methodology, I don't want to say the lifespan, but mRNA does degrade fairly quickly, and I don't have a number on that. And so the technology itself is something that is fairly novel, but ultimately what it's intended to do is to mimic what happens in a naturalized environment, right? We come in contact with the virus then attaches through those spike proteins, and in particular the ACE2 receptors in the linings of the throat and the nose, etc. But then also passes on the genetic information to be able to change the other cell, right? The host cells, which then become more viruses and it begins to propagate. And so outside of the technicality of it, as far as I'm aware, I've heard some of those things. And I mean, to change your own DNA, I can't speak to that. I don't know. I don't believe it. It does. I don't believe it does in how it's designed and what the processes are. And I'm not a geneticist, so I think to speak to that would probably require somebody with a little bit more technical knowledge in that area. But as far as my working knowledge of that is that no, it doesn't do that. And part of the reason why they have to have these freezers that go down to -80 is because it's very sensitive and the lifespan is very small. And so I can totally understand the concern. I can totally understand the fears and the nervousness about that, but I do not believe that is how that mechanism would take place.
So I've also heard about other potential treatments that are coming along, like some of the ones you even mentioned that are fairly successful. So how would that impact the utilization of a vaccine? Like, is this something that you think that we might need a vaccine for, like the flu and like some of the other things? And just to be clear, I'm 100% pro-vaccine for like MMR and stuff like that. I think there's a bunch of ones that probably aren't necessary.
Yeah.
Those ones definitely. This one for me, again, I'm a little skeptical. If we don't turn into zombies, then maybe I'll change my mind. No, joking, obviously, but I know there have been some adverse effects. Like I know if you have, oh gosh, I wish I remembered what it was saying. If you have certain allergies, you have there's a bit of a list of things, because my mom is a nurse and it's mandatory to take them where she's working, right? And so she had kind of a list of these things, and she has some of the issues on the list, and I can't remember exactly what they are off the top of my head, but that does sort of limit who can take them. And I know that some places were even talking about like restricting travel if you didn't have that, almost like a health passport or vaccine passport. But is this something that does require a vaccine, or are there alternative methods that we might look at for kind of dealing with this?
Yeah, I think you probably would get two different, well, there's probably multiple opinions, but in looking at the recovery rates and looking at some of the nuance that we're seeing with this, I mean, there's clearly people that want a vaccine for it. And so, but the question of does it need it? I don't know if I could speak to that in a way that would do it justice, because I mean, we'd have to define what is the need. I mean, I think that's going to be an individual factor that people have to decide for themselves. And, some people need it. Some people absolutely want it. Others say, I don't want it. I want to, go this route instead. So I'm more for the leaving the option open. I mean, have them available. If people want it, they can get it. If they don't want it, they don't have to get it. But I mean, I think there's a lot of push on that right now, and I can see why, because we're in a state where we need to have rollout of this vaccine to be able to cover some of the circumstances that are happening. I mean, we're still at a point where it's like, okay, we need the assistance, we need to get it out there. But I don't see as much on the treatment side, and that's where I'm like, okay, well, we have these other tools, and I see a vaccine as a tool as well, right? It's a tool, it's a resource. Let's have it as in our arsenal, but let's not overlook the rest of our toolbox as well. So yeah, I don't know if I could do that justice, because there's going to be people who will disagree with me. There's going to be some people who are like, yeah, that makes sense. That's kind of a balanced approach. So I would like to see more treatments. I would like to see a bigger emphasis on treatments, not to diminish the vaccine by any means. I mean, there's relevance and importance to both, but yeah, that's a tough one.
And one of the things that I'd love to get your input on is obviously one of the big comorbidities for COVID is obesity.
Yep.
One of the things that I wanted to know about was if an individual is overweight or obese, but they do begin, let's say, an exercise and nutrition regimen.
Sure.
Just doing that, how much of an impact could that potentially have on either reducing their risk of infection, or probably more likely just increasing their risk of being able to bounce back from it?
I would love to get a number on that. I mean, we've been batting that same idea around for a while, saying, how can we do this? I mean, I don't have access to humans right now, so I can't do any human studies. And so we're trying to figure out, okay, can we try and look at this in an animal model and see if we could do something to try and answer that question? You know, as you know, going back to my practitioner self, working with patients who, well, one had cancer, but also there were a number of them who were obese. We would really work to try and decrease that obesity. You know, that's a big thing. So I would say a number of folks would probably concur that, you know, anything is better than nothing at this point, because we know the benefits of exercise. I mean, it's widespread. And if obesity is one of the largest factors that's involved with this as being a risk factor, and I mean, it goes without saying, there's a number of I don't want to say partner risk factors, but there's a lot of other risk factors that tend to go together with obesity, right? I mean, if we're talking about perhaps metabolic syndrome or cardiovascular disease, or, you know, history of atherosclerotic events, or, you know, I mean, that goes in the cardiovascular disease, but you get where I'm saying, that there's a lot of these other things, chronic low-grade inflammation. I mean, so I would say anything is better than nothing at this point to get people to drop that risk score and you know, to be able to live a healthier life. I mean, it's only setting them up for something better. So in preparation, in the event that something does happen with the disease.
Awesome. And so maybe, so gyms aren't open here, so people don't have access to a gym unless they have their own,
right,
you know, in-home facility or equipment that they purchased during the lockdown. I know a lot of people really struggle to do workouts at home.
Mm-hmm.
I definitely do. I do not like it.
Likewise.
But
Yeah.
Would going for like a decently long walk and maybe, you know, incorporating some hills and some different inclinations and things like that.
Yeah.
Do you think that would have any sort of like meaningful impact on just general health markers for them? Because I know it does have an impact on health markers, but
Yeah.
from the standpoint of a recovery or prevention standpoint for COVID specifically.
Yeah, I would say, you know, anything can help. The more that people can get active and reduce some of those other risk factors, I think the better. And again, you know, probably going to have folks who will disagree with that and say, no, we have to have everybody isolated and locked down and keep to your own thing. But again, it's one of those things where we know what exercise does, we know the benefits of it, and we know the risk factors. So what has more weight, right? So what has more weight? And personally, you know, on the side of the gyms, you know, I would opt for the gyms being open. I mean, and we have some gyms that are open. I utilize the one that I have access to on campus. Nobody goes in it, but for me, I have to exercise. Like it's just one of those things, like, you know, I've got to exercise, you know. And so trying to get people active, I don't think it's doing them. I mean, it's a disservice for those that want to be active and want to exercise. But again, we have to kind of keep that in the context of what public health would say. So I think what's happening is now, at least in Southern California, they've moved everything outdoors. I mean, what an event, right? To take most of your gym, all of your weight equipment, all of your, you know, aerobic exercise equipment, move it outside, pay for a tent, and then have people do things in the parking lot. So I think there's ways that they're trying to do this, but yeah, people need to be active. I mean, it's like we could do some benefit on the back end, right? We could be helping this thing on the back end by reducing some of those risk factors. So why aren't we using, again, that's another tool in our arsenal. So if we can do it safely and if we can do it within the guidelines, let's get people moving.
Yeah, 100%. And even from a mental health standpoint, I know that,
Totally.
what is it? I can't remember. this is something that I read a long time ago, but it was like the top 5 non-pharmacological interventions for like depression, anxiety, PTSD, and things like that were like regular exercise, nutrition, having a job, having social interactions, and having a relationship.
Yeah.
And all of those things seem to be taken away right now, which ends up creating this weird, sort of dangerous cocktail. I mean, like I have PTSD, and I definitely know that if I don't have like really brutal workouts, that I'm not the same person. I can't function. So I'm very lucky that I do have a gym, access to like a garage gym that I go to, which is super helpful. But I know when I was in Ontario last year, it was a different story. I was staying in an Airbnb, and I was kind of stuck, sort of, and so I had like a single resistance band, and I'd go work out at like 2 a.m. because everything was off. So I'd work out like on a park at 2 a.m. So there's like no one there, and I do some pull-ups and some dips and things like that. But it was kind of wild because the whole time I'm like looking around, making sure that like cops aren't going to chase after me. We're doing split squats, and I was like, this is a wild time, you know?
Yeah, totally. Yeah. I mean, when we first got locked down, I live in an area where there's a 24-hour fitness nearby, and they have outdoor equipment. I don't know exactly why. I mean, it's simple, right? Dip bars. They've got some balance beams. They've got, a couple of benches for doing little things. And so I would go there because I'm like, I have to do something. Like I got to be moving. But yeah, I mean, it's trying to be creative in this circumstance that isn't conducive for some of these positive health benefits. So
awesome. So we talked about a whole lot of different things. We kind of bounced around quite a bit. I kind of wanted to just open it up to you to, if you wanted to kind of like talk about something that you think is really important or pertinent for people to kind of understand about the situation and about the direction that we're headed in. So, I mean, if you do have anything to share or say, I mean, take the mic. It's yours.
Yeah. One of the things that I've noticed too is that there's a couple talking heads on Twitter that are very negative, right? So there's some folks that are just fear. And I would say, if I wasn't in this field, if I didn't have my nose in the data every single day for what I'm looking at, I would see that being a challenge to me as a person, like, oh, I should be afraid. Like this person is saying, be afraid. But I would say be cautious and use a level of critical thought when reading through things or seeing things on social media. Go back to the original source, go back to the literature. But I've challenged some of these folks on Twitter. I'm like, you're scaring people. Like fear works as a motivator for some people, but I don't think it's working anymore. And again, that's for the behavioral people. But what I have seen is that in the response from people to these very fear-inducing comments, it's like, oh my gosh, what do I need to do? But then I challenge these folks like, hey, you got to give them something. You have to give these people something to go off of instead of here's something to be afraid of. Give them 5 steps to improve their own circumstance. Give them some information. Tell them to get in contact with these professionals. Give them resources instead of just dumping on them all of this, fear-inducing information. So I would say be careful what you read. Be cautious about things that are coming across, even from folks that you feel maybe respectable. It's check everybody, check me, check my team, check everybody. That's something that I think as a consumer of information, we need to realize that as we consume, we need to put some checks and balances on things. And I always say that to my students, to people that I'm working with, to even people who read our papers and go, I don't agree with you. And that's great. That's fine. And I'm happy for that. But go back and find the resources, find the information, go back to the literature and see if you can substantiate claims or refute them. And that's pretty much been really helpful, I would say, in talking with people in my community, and at least, my family or extended family or friends and student population as well, is to say, you got to check it. You just got to follow up.
Yeah, I think that's an excellent point, especially because of the frequency that we're probably seeing these messages. I mean,
Yeah,
I specifically don't go on Facebook anymore
me
because
neither.
it's just so negative. And I mean, the only people that I follow on Instagram are either powerlifters or
Right.
scientists or doctors like yourself.
Yeah,
So it's a pretty limited scope of people.
totally.
Even with that, sometimes like I get bombarded sometimes with certain things. I'm just like, oh man, this is too much. Like I'm getting anxiety from looking at this, and
Right.
you don't realize it because I mean, it's just so prevalent. It's everywhere. You're getting it from outside. You're getting it from the news, at work,
Yeah.
your friends, your family. It's like we're in this kind of constant state of crisis, which
Hmm.
definitely doesn't necessarily do anything positive for you. So
Right.
I think that's a really great point that you brought up. Is there anything that any projects you're currently working on right now that you wanted to kind of share?
Yeah. So some of the things that my lab in particular, I'm moving. I've been moving more toward the immunological for the past couple of years, and so I've got a couple things going on with our psychology department, but I also have looking at some biomarkers, and that stuff's kind of been on hold in terms of those research lines. But a couple things that we do have coming up related to COVID is one, the piece that I talked about having a call to action from the prevention side to say, this voice is being, I don't want to say it's stifled. It's not stifled. It's just not there. Is to say, hey, we can do something else. Like this is a resource that people can have. And it's something that public health and even the field of where I'm in, we say exercise, eat right, do all these things, prevention. And even public health is saying, hey, wave the flag, obesity is through the roof, cardiovascular disease through the roof. I mean, we're in some dire predicaments in the United States, and it's moving that way globally as well. So that's one piece that we're working on, and that's going to be multidisciplinary, and folks from friends of mine and people that I've worked with over the past bunch of years working on that to have a voice in it. Another thing too is we're looking into viral load. So viral load is one of those other questions that have come up related to the transmissibility. And some of the papers on transmission do mention viral load, basically meaning that wherever SARS-CoV-2 or any of the variants are within, whatever, if it's, we mentioned fomites versus aerosols versus droplets. And so however it gets out there, you come in contact with it, there is a level of viral load. And so we're trying to dive further into that as well. But my team, in fact, I don't want to take any credit for their work. I have jumped on board with some of the team here, but I am part of a nanomedicine group. And so the team that I work with, fantastic and way smarter than I am. And so they have a couple nanomachines, and they're looking at how those can actually disrupt cell walls and basically invade a cell. And these things are hit with a wavelength of light, and the rotors on them spin about 1 million times a second, and they'll just rupture cell walls. And if you had a drug, it helps for drug to get into the cell itself. So they're looking at a couple of bacteria right now, but we're moving toward the next phases of trying to see how we can move into the viral. What that has with this circumstance, I'm not entirely too sure. But I also have a couple other projects, ones that I'm kind of on the scientific advisory boards for, and looking at a couple of cancer drugs. And again, some of these that haven't been brought to market yet, but recycling of a couple cancer drugs to bring them to market so that they can actually be utilized and tested in studies. So that's on kind of I would say it's not my forefront burner, but it's definitely there. And then I've got a number of projects that I've been in writing phase for the last, this last year. I mean, we wrote on this COVID stuff, but I've got a number of projects that from like 2 years ago now that I've got to try and finish as well. So I keep busy.
Yeah, it sounds like it. Well, that's awesome. It sounds like you have some really exciting things going on over there. So where can people find you? Where are you most active on social media?
Instagram is really good. I don't tend to interact a lot. I interact more on Twitter, and I can give you those links, or if you want me to mention them to you. I know. Would it be easier just to mention them, or to?
Yeah, you can mention them, and then I'll also put the links in the in the description.
So you can find me on ResearchGate. You can see some of the work that's been done. If you just look up Brent M. Peterson or Dr. Brent M. Peterson, that's on there. Twitter, you can find me at Brent M. Peterson, PhD. I believe that's the handle. And then my Instagram is Dr. Brent M. Peterson, and you should be able to find me there as well. I don't interact as much. I try and post things that are cool to me, but most of the time I'm far too busy to really have conversation through social media. But yeah, those are the best ways to find me.
Awesome. So all that stuff is going to be linked up below. Definitely go make sure you give them a follow. And if you are familiar with research and reading it and statistics and kind of interpretation of it, then feel free to go ahead and check out his work. He's got some really cool papers. So, you'll probably get a kick out of that. Brent, thank you so much for jumping on, man.
Thanks.
It was a little tricky for me because this is way out of my scope. So every question I was asking, I was like, I'm probably butchering this question, but
no, you did great, man.
It's super interesting hearing everything you had to say about this. And it's, I'm really excited to be able to bring this podcast out because this is something I think a lot of people really want to know a little bit more about. So thank you so much, man.
Awesome. And if anybody wants to ask questions, I'd be happy to answer emails. So I can give you that as well. My email is Brent, BRENT .Peterson, PETERSON at Biola, B as in boy, IOLA.edu. And I'm happy to help.
So again, all that stuff is going to be linked up in the show notes, guys. Make sure you go check that out. Brent, again, thanks so much, man.
Yeah, thank you.